Okay, so let's start with the next chapter, that is arch expansion. Which arch specifically you talking about? We are giving more emphasis on the expansion of the maxillary arch, but expansion of the mandibular arch can also take place. Introduction. Expansion appliances are used to improve the transverse inter-arch relationships based on the frequency of activations, magnitude of the applied force, duration of the treatment, and patient age. Expansion of the maxillary arch can be classified into rapid, semi rapid, and slow maxillary expansion appliances. Now, what are different types of expansion? We can have orthodontic expansion, orthopedic expansion, passive expansion, and rapid maxillary expansion. Classification of expansion appliances. For maxillary expansion appliances, we have slow expansion appliances, which could be removable or fixed. For rapid expansion appliances, we can have banded RME or bonded RME, and we can also have surgically assisted rapid palatal expansion, also known as SARP, and also mini screw assisted rapid maxillary expansion, also known as MARP. Then for mandibular expansion, we have lower plate called as Schwartz plate. Now, what are the causes of transverse maxillary deficiency? Like, why do we need expansion in the first place? Like, what are the etiological causes for collapse of the maxillary dental arch? We have habits, specifically the thumb sucking habit as well as the mouth breathing habit. Then we have obstructive sleep apnea. We have iatrogenic effect. Example, whenever we repair the cleft early in the age, whenever the nasal maxillary septum has been damaged due to the formation of scar tissue, and it doesn't allow the development of the maxilla both in the anteroposterior dimension as well as in the transverse dimension. So that is one of the causes of transverse maxillary deficiency. We have palatal dimensions and inheritance issues. The reason could be muscular in origin or non-syndromic palatal synostosis, and because of environmental multifactorial causes also. Now, because of certain syndromes, we can have Klippel-Feil syndrome, cleft palate syndrome, congenital nasal pyriform aperture stenosis, which does not allow transverse expansion of the maxilla. We have Marfan syndrome, craniosynostosis by Eppert syndrome, Clausen disease, and Carpenter syndrome. We have osteopathia stratia, Treacher-Collins syndrome, and Duchenne muscular dystrophy. So, all of these factors in unison or independently can lead to development of transverse maxillary deficiency, which requires the use of any appliances to cause the development of the maxilla in a transverse dimension. Rapid maxillary expansion. Who is called the father of RME? It's Emerson C. Engel. There are two people, Edward H. Engel, who is called the father of orthodontics, and Emerson C. Engel, who is known as the father of rapid palatal expansion. Now, what are the indications of RME? Maxillary constriction, which has narrow maxillary base of wide mandible. Whenever there is skeletal class 2 division and malocclusion with or without posterior cross bites. In case of high palatal arch, then whenever we have class 3 malocclusions, borderline skeletal class 3 cases, pseudo class 3 cases with posterior cross bite or constricted maxilla, patients with cleft palate and lip with collapsed maxilla. Now, it is also indicated to gain the arch length in patients with moderate tooth size, arch length discrepancy, to widen the maxilla, to make the smile look more attractive for cosmetic purposes. For cosmetic reasons also, nowadays patients are opting for this procedure. And one of the medical requirements of RME is poor nasal airway, septal deformity, recurrent ear, nasal or sinus infections, allergic rhinitis, asthma, and before septoplasty. So we have to, in conjunction with an ENT surgeon, who is also known as otorhinolaryngologist, in conjunction with them, we can do this procedure of expanding the maxilla in a rapid way. So that increases the nasal airflow, reduces the resistance to airflow, and hence can be used to, and this can also be an effective method of treating mouth breathing habit, as we have already discussed earlier. Now, applied anatomical aspects of the maxilla. As you see, the maxilla is a very complex bone, right? It is a pyramidal shaped bone which is articulated, which is joined with so many different other bones in the craniofacial skeleton by means of intermaxillary sutures. There are many sutures present. So this is the maxilla. This is one half of the maxilla. This is another half of the maxilla. So now, as you can see, there are so many sutures which is attaching the maxilla together. We have frontomaxillary suture, we have lacrilomaxillary suture, we have nasomaxillary suture, intermaxillary suture, ethmoidal maxillary suture, and zygomaticomaxillary sutures, right? So there are so many sutures from the frontal aspect. If you look at the maxilla from the side, from the cross section of the maxilla, so you see that the maxilla is attached to the zygomatic bone, the nasal bone, the frontal bone, sphenoid bone, temporal bone, articular fossa, and lateral pterygoid plate of the sphenoid bone, as well as the hamulus part of the sphenoid bone. So the maxilla and also the palatine bone. So maxilla has a very complex anatomy. Specifically, whenever it is attached to the craniofacial skeleton, whenever we are wanting to undertake any rapid maxillary expansion protocol, we have to loosen these all many sutures to be able to expand the maxilla in a transverse direction, and hence rapid maxillary expansion is also one of the most difficult tooth movements to achieve, and also the most difficult to retain also later on in the life. Another applied aspect is that these figures show histological features of sutures at various age. We are talking about the intermaxillary suture here. We are talking about the mid-parietal suture here. So early in the age, this mid-parietal suture was in the form of a Y. So this is the premaxilla, and these are the both maxillae. So the sutures are in the form of a Y or V shape, which is more or less a straight line. So if any RME protocol is instituted early in the age, that is met with beneficial results and more stable results, because it is easier to move the maxillae sideways, because the bones are not properly interdigitated with each other. Now, A figure was for infancy, B figure is for juvenile ages, that is during the teenage time, and C is the adolescent or young age. So as you can see, the tortuity or the interdigitation of the bones of right side of the maxilla and the left side maxilla, they interdigitate in a more complex manner as the age progresses. So as the age progresses, it is even more difficult to separate the maxilla together in a skeletal manner. So earlier the better. Earlier the treatment is instituted, the better it is. Hence, the more optimal period for performing RMA procedures is between 8 to 15 years. Between 8 to 15 years. Right? Now, what is the mechanism of RME? Whenever any appliance is put on the teeth and it is applying too much of lateral sideways pressure, so heavy forces are directly transmitted to the sutures by compressing the PDL and by bending of the alveolar bone. So in this case, the teeth and the PDL act as handles. They act as handles to forces to the sutures. Which sutures? We are talking about so many sutures which we just talked about earlier. Now it is followed by opening of the sutures plus tissue injury plus proliferation of the repair mechanism. There is inflammation, there is osteoclastic activity, osteoblastic activity, there is formation of the bone, there is resorption of the bone. So it is basically followed by excessive inflammation. So that is why it can result in a painful sensation to the patient. So the tensile forces on the suture initiates bone formation between the sutures. As we have already seen earlier in the biology of tooth movement chapter, whenever there is tension, there is bone formation, and whenever there is compression, whenever there is pressure, it leads to resorption of the bone. And finally, it is followed by healing of the suture by proliferation of the fibroblasts and repair sutural connective tissue before osteogenesis and remodeling can take place. So this is the basic mechanism of RME, how the forces which are acted upon by the teeth, how the forces are withstood by the teeth, how they are transmitted to the sutures, to the circumzygomatic, to the circummaxillary sutures, how the sutures get loosened up, and how the maxilla separates from itself in a fan-shaped direction. Now, as you can see the maxilla from the front, you can see the direction of opening of intermaxillary sutures is in a triangular way, or it's in a pyramidal form, with the base at the at this area and apex at the floor of the nose. So that means whenever the maxilla is separated, we see the development of a midline diastema here, and more amount of maxilla is separated in the teeth in the alveolar region, and less amount is separated in the nasal floor region. Reason being, as we go above in the maxilla, the articulations of maxilla with so many different bones, it increases. That's why it becomes more and more difficult to separate the entire maxilla in a sideways direction. So that's why this is the diagram which shows the direction of opening of intermaxillary suture, which is pyramidal in shape with the base at the alveolar part of the maxilla. Similarly, if you look at the transverse aspect of the maxilla, here you see whenever forces are applied, the maxilla opens in a fan-shaped direction with the base at the incisor teeth. So that means more amount of opening is seen in the anterior region, and less amount as you go behind, less and less amount of opening is seen. So why lesser amount of opening is seen in the posterior? Because of something known as buttressing effects of bones at the posterior maxilla, specifically the pterygoid plates of the sphenoid bone. So as the same concept applies here as well. As we go behind, as we go towards the center of the as we go towards the axial plane, or as we go towards the longitudinal axis of the body, the buttressing effects takes more importance. That means the maxilla is articulated by the pterygoid plates of the sphenoid bone, as well as hamular process of the sphenoid bone, along with so many different bones. So it becomes all the more easier to separate the maxilla at the anterior region rather than at the posterior region. Hence, the direction of opening of mid-palatal suture is again, it's in the triangular manner, with the base at the maxillary incisors and apex towards the pterygoid plates of the sphenoid bones. Now, as you can see in this figure, this is one RME appliance which is called a Hyrex appliance, which is cemented onto the teeth in situ before opening of the suture. So here the sutures have not yet opened, and there is no midline diastema, as you can see here. Whereas in the second figure, you can see the sutures have started to open in a fan-shaped direction like this, and there is presence of midline diastema, and the maxilla is trying to separate in a sideways direction. More amount is seen in the anterior, lesser amount is seen in the posteriors. So as you can see in this figure also, here the midline diastema is extremely well pronounced in cases of expansion by the fixed RME appliance. The same patient, whenever we see from the front, at the beginning of the rapid expansion, there is no midline diastema, and whenever the expansion has taken place, there is development of significant midline diastema. So this appearance of diastema is a telltale sign that maxillary expansion has taken place. right? So this is a clinical indication whether expansion of the maxilla has taken place or not. That is ascertained by the appearance of midline diastema. If there is no diastema, we have to increase the force levels. If there is diastema, we can be rest assured that the maxilla has expanded in a lateral direction. Now, what is the mechanism behind? I've already told about the mechanism behind expansion. Now, if we compare rapid expansion with slow expansion, now what happens? The red graph here, it goes up and then it goes down, right? Whereas the green graph, it follows a more or less straight line, right? The reason is whenever there's skeletal expansion, the teeth separate too much. The teeth separate, the diastema appears too much. That is because of skeletal expansion. The maxilla itself has separated, right? But over a period of time, suppose the weeks are plotted against the x-axis and expansion in millimeters is plotted against the y-axis. So if you allow the expansion device to be there for subsequent number of weeks, like for example 8 to 10 weeks of time, so ultimately what happens? Ultimately, both skeletal and dental expansion, they conglomerate together and the ratio is the same. Like in this case, in RME, initially the skeletal to dental expansion ratio is 4:1 and finally the expansion ratio is 1:1. Why this happens? Because once the teeth are separated from each other, there is pull from the transseptal fibers and dentogingival fibers. That means there is a relapse. I'll tell you more about this in once we talk about relapse and retention later on in the series of lectures. So what happens whenever the dentogingival fibers and transseptal fibers specifically, they exert pulling force on the teeth. So these fibers which are present on both incisors, for central and central incisor on one side and central incisor on other side, they both pull together and hence that leads to closure of space, closure of the diastema between the central incisors. So this takes time. Ultimately, the skeletal to dental expansion ratio in the long run is 1:1. In the short run, it is 4:1. So this is an MCQ question for you people. In slow maxillary expansion, however, this expansion ratio is 1:1 throughout because so much of skeletal expansion is occurring. Similarly, the dental expansion is also occurring in the same way because we are expanding the maxilla in a very slow manner. We are expanding the maxilla in a very slow manner. Hence, it is called slow maxillary expansion. Hence, the transseptal fibers have enough time to pull the teeth together, and hence the amount of midline diastema which is occurring is 50% because of skeletal expansion, 50% of dental expansion. So the ratio is 1:1. What are the effects of RME? There is an appearance of midline diastema which can be anesthetic for some patients. There could be buccal inclination, extrusion of posterior teeth. The mandible rotates downwards and backwards, which may be due to extrusion and buccal tipping of the posterior teeth. So there is wedging effect. What happens once I'll explain you once we look in the coronal direction, once we look at the maxilla in the coronal direction. So whenever the expansion is taking place, there is buccal inclination of the crowns of the molars. So that leads to lower down tipping of the mesoparietal cusp of the molars, right? So because of this, there is wedging effect. This wedging effect pushes the mandible in a downward and backward direction. It opens the mandible in a downward and backward direction. So this is one of the iatrogenic side effects of rapid maxillary expansion. Then there is increase in arch perimeter. Atkin and Associates estimated that every 1 millimeter increase in posterior arch width gained by RME leads to 0.7 increase in arch perimeter, which was confirmed by McNamara. Right? So we have to remember these two values here. 1 mm of increase in posterior arch width gained by RME leads to 0.7 millimeters increase in the arch perimeter. And also effects of RME we have already discussed about. It leads to reduction in the nasal resistance, and hence it increases the airflow, and this can be a medical application of RME. Now, types of rapid maxillary expansion appliances. We have removable appliances, we have fixed appliances. In fixed appliances, we have banded ones, we have bonded ones. Right? Now, they can also be tooth supported, tooth tissue supported, or only tissue supported. So tooth supported can be, the examples could be RME appliance, or, and the tooth tissue supported could be Dirichlet appliance or Haas appliance. Now, this is a diagrammatic representation of Hyrex RME. Now, what is an RME? RME is rapid maxillary expansion. Hyrex, full form of Hyrex is hygienic rapid expander. This is the full form of Hyrex. Now, what is the pitch of the jack screw or pitch of the screw, pitch of the Hyrex screw? That is approximately 0.8 to 1 millimeters. What is the meaning of pitch? Pitch means if you rotate the screw by 360 degrees, that is the amount of expansion what you can achieve. That is the distance between the two threads of the screw. That is called the pitch. And that is equivalent to the amount of expansion which can be obtained by 360 degree rotation of the screw. That is called the pitch of the jack screw. So these are the examples of certain expanders. This is the Dirichlet type. This is the Haas type. This is the Min type. And this is the Hyrex type of expander. Now you can see A and B are tooth and tissue supported. Tooth tissue supported. Why? Because the acrylic plate is supported against the tissues and the bands are placed against the teeth. Then we have main expander here, which is only supported by the teeth, right? And we have Hyrex expander. So both of these are tooth supported. Okay. Then in RME plans, we have got two types. One is banded RME, one is bonded RME. Now, banded RME means we have to band the molars and the premolars, and the Hyrex appliance is soldered to these bands. Whereas in case of bonded RME, we have to just configure a wire along the buccal and lingual surfaces of the teeth, like this, in the form symmetrical to the teeth, to the posterior teeth, and over that an acrylic splint like appliance is fabricated by means of either rapid cold cure acrylic or heat cure acrylic, and the Hyrex appliance is incorporated within that, and the arms of the Hyrex appliance are soldered onto the metallic framework which encompasses the acrylic framework. So that is bonded RME. So banded RME basically is required in cases of horizontally growing patients, and bonded RME is required in patients of vertically growing patients. So now I had already told you about that one of the drawbacks is wedging effect. One of the drawbacks of molar expansion, maxillary expansion is wedging effect. That leads to overhanging of the mesopalatal cusp of the maxillary first molar. So that leads to rotation of the mandible in a downward and backward direction, and that leads to an open bite tendency. So this open bite tendency is negated by means of a bonded RME appliance in cases of patients having open bite tendency, or in patients having vertical growth pattern or hyperdivergent facial profile, right? Whereas we want such overhanging of the maxillary mesopalatal cusp in cases of horizontally growing patients having deep bite tendency or hypodivergent facial profile. So that's why banded RME are advocated in low angle cases, and bonded RME are advocated in high angle cases. How to manage the plans clinically? Rapid parietal expansion of plans is done with 2 turns daily of the jack screw, that is 0.5 millimeter activation each, which produces around 10 to 20 pounds of pressure across the suture. The expansion schedule is advocated by Zimring and Isaacson. There was another person called Timms who advocated that who advocated the expansion schedule, the activation schedule. So in young patients, he said 2 turns a day for 4 to 5 days and 1 turn a day for the rest of the treatment period needs to be followed. For adult patients, for the first 2 days, 2 turns per day should be given. For the next 5 to 7 days, 1 turn per day should be given. And during the rest of the treatment period, 1 turn is given every other day. Whereas Tim said, in patients under 15 years, of age, we can give 90-degree rotation in morning and evening. Means the activation has to be done every day. Whereas in patients above 15 years of age, we have to give 4 turns. Each of 45 degrees. So here we are increasing the frequency of turns and reducing the amount of the magnitude of turn. Whereas in patients who are lesser than 15 years of age, we can give a 90-degree turn twice a day, once in the morning, once in the evening. So every turn of the screw opens the plans by 0.25 millimeter. So each turn involves 90-degree activation. With rapid maxillary expansion at the rate of 0.5 to 1 millimeter per day, a 10 millimeter expansion can be achieved in 2 to 3 weeks. Now this is a clinical case scenario where spaces usually develop between the central incisors during rapid maxillary expansion. As we have already talked about, this is the midline diastema which has occurred, and this is a sure shot indicator. It is a telltale sign to ascertain whether expansion of the maxilla has occurred or not in the first place. Now, once the appliance is placed and treatment begins, there is only a very tiny diastema, as you can see here in this figure, in the first figure. After 1 week of expansion, the teeth have moved laterally with the skeletal structures. This is the second figure where the diastema is quite significantly pronounced. Whereas after retention, there is a combination of skeletal relapse and pull of the gingival transseptal fibers, which have brought the incisors together and closed the diastema altogether here. You can see there is no diastema because of the pull of transseptal fibers. They have pulled both teeth together and closed the diastema. After the expansion has taken place, we have to give a retention plate at least for 10 to 12 weeks. You see, expansion is a very unstable process. I told you earlier, because the maxilla is heavily articulated by surrounding bones, so it also has to undergo retention for a prolonged period of time because it is extremely unstable in stability. That's why retention plate has to be given for 10 to 12 weeks. So either we can give a acrylic retention plate having clasp and label bow, or we can just put a composite button into the opened jack screw, and that jack screw itself can act as a retention for a certain period of time, like for 10 to 12 weeks. Now, clean advantages and disadvantages of fixed RME. Advantage is that the patient compliance is not required and rapid changes are produced within a very short period of time. And disadvantage is like the appliance is very bulky, which is difficult to keep clean, and it also limits its use in young children in the mixed dentition phase. Clinical significance, pain and RME. I told you earlier, whenever there is inflammation because of bone remodeling, because of suture fabric, because of fibroblast proliferation, inflammatory mediators are there. So that is perceived by the patient in the form of noxious stimuli known as pain. So pain is felt in patients who are in late adolescence, above 15 years of age, and in adults due to buildup of the force. and slight discomfort may be felt during the expansion, and persistent pain is noticed in patients whose sutures are fused. In such cases, activation should be stopped. Now, talking about slow maxillary expansion, it is equivalent to dentoalveolar expansion. Slow maxillary expansion equals to dentoalveolar expansion. Now here only 2 pounds of force is given with the expansion carried out at the rate of 1 millimeter per week. So we have classified the expansion devices as removable slow maxillary expansion, for example, plates with jack screw, coffin spring, removable quad helix appliances, and fixed slow expansion appliances, for example, W arch appliance, Porter appliance, quad helix, niter paddle expander, as well as the fixed orthodontic appliances. So these are the figures showing coffin spring. The first figure shows a coffin spring. It has an omega shaped wire attached here. It has an omega shaped wire, and the two ends of the plate are activated just by pulling them separately like that, and then activating and putting in the patient's mouth. Then we have jack screw appliance. Here the jack screw is incorporated in the midline of the plate, and it is opened at the rate of it is turned at the rate of it is turned only twice per week, and each opening is of 90 degrees. Each opening is only of 90 degrees. That means 0.25 millimeter per turn activation, per turn expansion is advisable in such cases. That means twice turns per week means 90 degree plus 90 degree, and means 180 degree per week, or 0.5 millimeter per week expansion is advocated with use of slow maxillary expansion, specifically the jack screw. And third and fourth figure shows expansion screw, which is also known as Schwartz appliance, which is specifically used for expansion of the mandibular arch. Now we have fixed appliances in the form of quad helix appliance, which was introduced by Ricketts in the year 1975. It is made up of 0.036 inches hard stainless steel wire. So what is it exactly? You can see there are 4 helices. This is first helix, second helix, third helix, and fourth helix. And this particular appliance has certain components. This is called as anterior bridge, and these two are called posterior bridge. This is called posterior bridge. And these are the helices. These are the molar bands. And these wires are called anterior expansion appliances. Anterior expansion wires. Right? So how is it activated? It is activated using a 3-prong plier. It is activated using a 3-prong plier. So whenever we want to activate we want to cause expansion in the posterior arch. So how do we activate it? We activate it in such a way that the anterior bridge moves in a V-shaped manner. It moves like this, so that the posterior bridge, it moves buccally like this. So that causes movement of the posteriors in a buccal direction. Now whenever we want to expand the anteriors, we have to use the same 3-prong plier. And we have to make the posterior bridge in this direction. So this will lead to contraction of the posteriors and expansion of the anteriors by means of anterior expansion wires. They get flared out, and hence the expansion of the upper anteriors can take place. So this is the activation mechanism, which is done by using 3-pronged plier. So this is an example of the appliance which is placed intraorally. So what are the indications of quad helix appliance? Indications are narrow upper arch, crowded, mixed or permanent dentition, class 1 malocclusions where upper arch needs effective widening and upper molars need distal rotation. Then in class 3 malocclusions where upper arch needs effective widening. In thumb sucking and tongue thrusting cases where we can incorporate certain palatal cribs like appliance into the anterior component, we can even solder that onto the anterior component, anterior bridge, and it can also be utilized for correcting unilateral or bilateral cleft palate. Expansion of 8 mm produces 14 ounces of force, and average force which is provided is 200 to 400 grams of expansion forces. So another modification is incorporation of additional helix for anterior expansion. So these helices can be opened up, that can cause expansion in the anterior region, or that can cause proclination of the anteriors if there is a particular need for such situation. And in the second figure, although there is no additional helix, but still it can be used for anterior expansion. Just pull the two ends of the wire in this way, that will lead to expansion of the upper anteriors. What are the advantages, pros and cons of quad helix? It provides excellent expansion in cleft palate patients. Expansion is smooth and controlled. In young children, skeletal expansion can be achieved, but not in adult patients. It is only a means for dentoalveolar expansion. Anterior bridge with helices can act as a reminder for habit breaking, specifically the tongue thrusting plus digit sucking habit. So that can also act as a reminder therapy for certain habits. Disadvantages is that the buccal tipping of molars using excessive activation. We can have excessive buccal tipping of the molars. So this can be negated by incorporating something known as buccal root torque in the fixed appliance on the which is present on the labial surface of the teeth. Another expander called NITI expander, which was introduced by Wendell V. Arndt in the year 1993. So this expander is specifically used in cleft lip and cleft palate patients. So it is made up of two different materials. One is stainless steel and another is thermal activated titanium. Thermal activated means copper NITI wire. That means whenever this appliance is inserted into the patient's mouth, it has to be first cooled on a cool glass surface, on a cool glass slab, or it has to be refrigerated for some time. Then it is inserted in the patient's mouth, which makes use of nickel transition temperature, that is of 94 degree Fahrenheit, or the normal mouth temperature is around 37 degrees Celsius. So what happens whenever the copper NITI wire, whenever this appliance is inserted into the mouth of the patient, the heat activates this copper NITI and it allows expansion of the copper NITI wire into a transverse direction. So force levels are 180 to 300 grams, and there are different sizes available, which ranges from 26 to 44 millimeters, and which has to be selected depending on the intermolar width, right? So these are prefabricated appliances. They are available in the market. They are marketed under different brand names, under different brands. So they are just inserted in the patient's mouth depending on the intermolar width. Plus you have to add 3 millimeters. So that is the amount of expansion that is desired. We have to forcefully enter into the patient's mouth and then allow for the expansion to happen on its own. And after a certain period of time, you will see significant, magnificent results which can be seen in specifically in cleft lip and cleft palate patients by the use of this particular appliance. Now coming to surgically assisted maxillary expansion, also known as SARPE. As maxillary expansion in adults is not possible due to increased resistance to sutural split from the interdigitated mid-palatal and lateral maxillary sutures. Surgically assisted expansion would decrease the resistance at the same time, not totally freeing the maxillary segments. This procedure is followed by expansion with the jack screw. So basically what happens here, we are basically freeing the sutures. We are doing some surgical intervention in order to free up the sutures along with use of a jack screw. So once the sutures are freed, once the Hyrex screw is activated, that leads to ease in the plans getting activated, and that leads to more amount of expansion in a very short period of time. So it is performed with parasitial osteotomies in lateral wall of nose or medial floor of sinuses connected by anterior transverse cut. In adults, the cuts in maxillary lateral buttresses decrease the resistance to a level where mid-palatal suture is opened forcefully, that is, they are microfractured. And for SARPE, now surgeons often make all the cuts needed for Lee Fort 1 osteotomy, omitting only the final step of down fracture. So this surgical assisted maxillary expansion is very similar to Lee Fort 1 osteotomy, where a cut is made from all the way from the lateral border of the pyriform aperture. Here goes posterior intermaxillary osteotomy cut is also made. Here also mid-palatal suture osteotomy cut is made up to the pterygoid plates of the sphenoid bone up till here. So these are the cuts, and along with the Hyrex screw, this leads to expansion in both arches laterally, and that causes expansion of the maxilla in a very easy and sophisticated manner. Now we can use either a Hyrex screw or we can use palatal assisted maxillary expansion also using the same procedure. I'll be telling that also later on. Now what are the indications of SARPE? To expand the arch for correcting posterior crossbite, collapsed maxillary posterior crossbite, to widen the collapsed maxillary arch in cleft palate, for pre-surgical arch expansion even in planned orthodontic surgery, to prevent increased risks and inaccuracies with segmented total maxillary osteotomies. It can also be done when expansion required exceeds that which can be performed by segmental expansion. That is, whenever expansion is required greater than 8 millimeters, this procedure of SARPE can be advocated. And another indication is to expand the arch for creating space without premolar extractions. In cases where patients are adamant that they do not want extractions at all. So, if the space required could be gained reasonably due to maxillary expansion, in such cases also, this process can be advocated. Now, as you can see, these are the osteotomy cuts for SARPE procedure, more similar to the ones given for Lee Fort 1 osteotomy. Only difference is that we don't separate the maxilla completely from the rest of the facial skeleton. Like in Lee Fort 1 osteotomy, one step down cut has to be given at the posterior end of the maxilla. So this final step is omitted in cases of SARPE assisted rapid maxillary expansion. Rest all the osteotomy cuts are similar to that of Lee Fort 1 osteotomy. Now similar to SARPE, there is another procedure called MARPE, which stands for mini screw assisted rapid palatal expansion. Now in this case you can see this particular case requires expansion to be done because of this instanding lateral incisor here. So what is done here? Certain mini screws are inserted here in the palate just lateral to the mid-palatal suture, and Hyrex screw is incorporated into that. Along with the Hyrex screw, the rest of the skeleton of the appliance is soldered to the molars, similar to that of normal RME appliance. So expansion is taking place here. We have activated the appliance here, and that has caused opening of the midline diastema as well as increase in the arch width as well as arch circumference. The once sufficient space has been created here, this particular tooth will be bonded by means of an orthodontic bracket and it will be pulled into normal occlusion. Similarly, another case which shows the use of MARPE. Here the mini screws are inserted again. And the rapid palatal expansion device, that is RME appliance, is activated in both ways. Similarly, this leads to development of a midline diastema development of a midline diastema, and that's what causes expansion of the maxilla, and hence the usage of rapid maxillary expansion for increasing the arch circumference and arch width.